हेलो।
हॅलो, हा गणेश बोल क्या?
मॅडम, यूट्यूब लाईव्ह झालंय.
हो. आम्ही
ओके.
सुरू करतो तर 2 मिनिटात सुरू करते.
ओके.
चेअरपर्सनला लॉग इन करू द्या, मग आम्ही चालू करू.
मॅडम,
हा बोला. येस. Sir, actually, we started this webinar series uh, from for especially for the private practitioners, sir, who work on standalone basis and many times in resource limited setup. So we have included topics which are a challenge to all of us in our day-to-day practices.
अच्छा अच्छा.
This is
Really
third
great.
Very
episode.
very good initiative. Very good initiative.
Thank you, sir.
Nobody thinks of actually private practitioners. All are busy with corporate and college people. So that's a good initiative. You are thinking about these
Thank you,
practitioners.
sir.
I have practiced for 25 years. I know their difficulties in practice.
Yes, sir.
Yeah.
Yes, sir.
Good evening, everybody. Good evening, Pankaj sir.
Mm.
Rajuka sir.
Good evening, Dr. Dilip. Good evening.
Good evening.
Mm.
ma'am, can we start or we have to just wait for more time?
What do you say, sir? Should we start?
Yeah,
Or we'll just wait? Should we wait for 5 minutes or should we start?
we can wait for 5 minutes. How many people have joined till now?
People have
21.
joined in YouTube, so
20.
in Zoom 21, but people are logged in YouTube also, because we had given YouTube link also.
Yeah, okay, okay. No, we can start. We can start.
Okay, we are already live. I think we should start, ma'am.
Yes, I think so. Yeah.
Good evening, everyone. Here, Dr. Om Shubham Asai. Actually, I feel honored to stand before you today as we gather for this third episode of Get the Concept Right, which is organized by the Indian Society of Anesthesiology, Nagpur City branch, in collaboration with the Society of the Anesthesiologists, Maharashtra State. This webinar series continues to be a beacon of knowledge, fostering dialogue and exchange within the field of the anesthesiology. Today's session promised to be exceptionally enlightening as we delve into a crucial topic that touches the core of our practices. We are privileged to have two distinguished speakers with us, Dr. Pankaj Kundra and Dr. Dipali Mandlik, sharing this expertise with us. Guiding us through this enriching session, as we have our esteemed chairperson, is Dr. B.M. Rajulkar sir, whose leadership and expertise in the field of anesthesiology has been very instrumental in shaping the landscape of our profession. Now, I am very delighted to extend a warm invitation to Dr. Gauri Arora ma'am, the president of the ISA NCB, to deliver the welcome address for the today's Get the Concept Right webinar. Dr. Gauri ma'am's leadership and expertise will set the stage for an enlightening and productive session. And over to you, ma'am.
A very good evening to all of you, respected seniors, President SAMS, Dr. Balaji Asegaonkar, Honorary Secretary SAMS, Dr. Rajesh Tagadpalli, and Maharashtra GC, SAMS GC, Dr. Sheetal Dalal, our eminent faculty, respected Dr. Pankaj Kundra sir, and our faculty member, Dr. Dipali Mandli. All my friends, colleagues, I welcome you all to the third episode of get the concepts right. This is a webinar series which has been started keeping in mind the private practitioners who work on standalone basis and in the peripheries, in resource limited setups. And we have always included topics which we as anesthesiologists face on day-to-day basis. So today we are going to talk about the challenges in airway, dealing with the challenges in airway in two special category of patients. One is a pediatric one, and one is a difficult airway patient. Like intubation is a and patients with difficult airway is already a challenging task. And extubation in such patients, it puts the patient more at risk, and one always has to think of possibility of re-intubation in such patients. So extubation in these patients has to be well planned, well thought, and well timed. So we are fortunate to have Pankaj Kundra sir to share his insights on this complicated topic. So sir, welcome to this webinar, and I welcome all the members who are attending today's webinar.
Thank you very much, Dr. Gauri, for this kind invitation. And it's my honor to be here to be sharing my thoughts on extubation in difficult airway. Indeed, it's very nice to talk to colleagues who are who are in practice and give some, maybe we can share some points which can help us in our daily practice when we do anesthesia. So with this words, if I can go around to my presentation, I'm going to share my screen with your permission, ma'am. Can I start?
Yes, sir, you can start. I have stopped my sharing.
Thank you.
Sir, just a second. I will a little bit of introduction for a minute.
Yes.
So good evening, all of you. First of all, I thank ISA, NCB, and SAMS for honoring me to chair this webinar series. Get your concepts right, and I congratulate ISA, NCB, and SAMS for taking initiative to start this series, especially for private practitioners. And first topic for today's webinar series is extubation in patients with a difficult airway, and the other is intubation and extubation challenges in pediatric patients. And we have eminent faculties with us today to talk on these two important topics. Friends, our general viewpoint is intubation is more important for any general anesthesia sequence. We are more worried about intubation initially. And much of our attention is focused on the difficult airway management on intubation. But here I want to say that successful management of the difficult airway, however, does not end with the placement of the endotracheal tube alone. But extubation is also as important as the intubation. And as extubation at times may go wrong and resulting in serious consequences to the patient, especially in difficult airways and in many other situations. So here I wish to put the audit project report of Royal College of Anesthetists in the United Kingdom, which demonstrated that 1/3 of the major complications of airway management occurred at extubation or in the recovery room with a morbidity rate of 5%, which is quite alarming. And looking at that high incidence of complications, the Difficult Airway Society, that is DAS, they have published detailed evidence-based guidelines for the management of tracheal extubation in adults, which are largely applicable to children also. Thus, anesthesia practitioners should be familiar with those extubation strategies developed by ASA Task Force on management of the difficult airway and DAS. So I think let us hear from Professor Dr. Pankaj Kundra, the eminent faculty, the current concepts about extubation strategies. Please, sir.
Thank you. Okay, let me start with the presentation. So we'll be talking about extubation practices. Slides are not moving. stuck.
Sir, are you facing any difficulty?
I was not able to move the slides. I am not able.
And now is it moving? Otherwise, we take help of the technical people.
Sir, just click on this slide and then you can move it. Yeah, now you can click on this. Yeah, now you can move it the slide. Yeah, now it is fine.
Yeah, it's fine.
Yeah,
Thank you.
okay, sir.
So, starting with extubation practices, which can be performed in India. So, what are the current extubation guidelines and practices? Let us first go through that. So, as you would be aware that we published the All India Difficult Airway Association guidelines for extubation in 2016. So, leaving apart the Western data, this is the data which we have, or the group comprises of the subcontinent, and we tried to frame the guidelines. And the feedback which we got was very interesting, and it was felt that these are very robust guidelines which can be applied to all scenarios. So this was done in 2016, and we are in the process of revising the guidelines. The committees have been formed and the work is already on. Can we have the mic muted, please? Yeah, thank you. So this is the guidelines, the algorithm which we had made it as simple to have 4 Ds, 3 S's. So I'll be going through this in some part of time to tell you how difficult extubation can be performed in such cases. So if you look at this algorithm, the middle and the right limb tells you about 4 Ds. These are difficult mask ventilation, difficult intubation or re-intubation, delayed delivery, and difficulty because of pre-existing diseases. And the right side limb, just for us to remember, is 3S, which are surgical cause of airway compromise, suspected airway edema, and suspected airway collapse. So this is how we made 3 limbs. And we will go through them to see how we can manage these kind of scenarios. So once these guidelines were published, we passed on a survey on tracheal extubation practices, which is currently being done in India. So we had about 1,500 participants, out of which the questionnaire was sent to them, and out of that, 1,264 or 84% responded. The experience, if you look at the 84 people who had 84% who had responded to the survey, about 47% had experience of 10 years, 33 between 3 and 10 years, and the least, or the 21%, were probably the postgraduates who had an experience of less than 3 years. So the majority of the chunk of survey was generally responded by the people who had more than 3 years of experience. So we talked about anticipated difficult intubation to see what is the scenario right now in India. So as far as device exchange extubation was concerned, we found that of the 84 respondents, 48.3% respondents, they would choose an airway exchange catheter if they encounter a difficult extubation. About 19% of them would do an exchange with a supraglottic airway device, and about 9.5 to 10% would exchange it through a fiber optic endoscope or a video endoscope. The duration for which the AEC was kept after extubation, less than 2 hours, about 60.3% respondents said they would keep it for that much time. And for more than 12 hours, it was 4.6% of the respondents said that they would have kept it for that long length of period of time. But just to tell all of you, the recommended duration for which we can keep an AAC in place is 2 hours. Beyond that, there is no point in keeping the AAC. So luckily, we see that majority of them who had used AAC had kept it for less than 2 hours. Now let's look at the most commonest scenarios which we encounter, like the surgical cause of airway compromise, suspected airway edema, and suspected airway collapse. So I'm going to talk about suspected airway edema first. So when we suspect an airway edema, the recommendations are we do a leak test. So 70% respondents say that they do perform a leak test and then do the extubation, where 17% said they were not sure. And out of those 70%, only 47% used qualitative methods, not quantitative methods. If there was a suspected airway collapse, then 55% respondents said that they will have the patient extubated when the patient is fully awake and observed, while 34% respondents would do a deep plane extubation over AEC or fiber optic bronchoscope. What happens if you have a surgical cause for airway compromise? So 65% respondents said they will electively ventilate the patients for 24 hours, 15% will extubate over AEC, and 17% said they would perform a tracheostomy. The word of caution here is when we talk about 3Ss or the head and neck surgery, according to the evidence which is gathering, is about this limb. And if you look at this article, which was published in 2016 about the tissue transfers from head and neck reconstruction, they had recruited 180 consecutive surgeries in which 63 patients had immediate extubation, while 117 patients had delayed extubation. And what were the results? Interestingly, the ICU medical complications rate was higher if there was a delayed extubation versus 12.7% only if it was a immediate extubation. So what do we see? We see that the ICU medical complication rates is extremely high if you delay extubation, thinking that you would take time and then remove the endotracheal tube. So the conclusions were that if you want to decrease the medical complications, you must plan for immediate extubation rather than delaying it for a length of time. What about planned tracheostomy in advanced cancers? I think this depends upon various factors, and the decision would be whether you are at the risk of airway obstruction because of swelling and edema, and it all depends upon the extent of surgery, whether there is going to be anticipated difficult airway post-op, and would you be able to rescue the airway. Third is whether there is a predicting difficult intubation preoperatively and a poor respiratory reserve. But the most important aspect which people forget to evaluate or assess is the cuff strength. Cuff strength is the mainstay of preventing post-op pulmonary complications, especially in old age, in reconstructive and free flap surgeries. If the patient doesn't have the ability to cough out well, they would retain secretions, and in no time, they would develop pulmonary complications, atelectasis, and that would increase the post-op morbidity, and the patients may land up with on a ventilator or on a tracheostomy. So what we need to do is at least assess the maximum negative inspiratory pressure. It should be around -20 centimeters of water to say that the patient has an effective cough. And this cough can actually be evaluated preoperatively itself. All you need to do is ask the patient to take a deep breath and forcefully expire and look at his ability, whether he's able to clear his chest. Normally, when we ask the patients to cough, what they would do is they will just try to clear their throat. So rather than talking to them post-operatively how to cough, it's better that we educate them during the preoperative assessment that they will be frequently asked to cough and clear their secretions. And if they're able to do so, then the pulmonary complications can be averted. The other aspect is about other kind of recent advances which has taken place. One of them is called as isocapnic hyperventilation to provide extubation after head and neck surgery. What they're trying to do now is what we used to practice about 40 years back. They're trying to infuse carbon dioxide to the inspiratory limb of a breathing circuit during mechanical hyperventilation. And if they see the patients who have been given sevoflurane anesthesia surgery lasting for three hours or more, they found that if you give isocapnic hyperventilation, the time to extubation is considerably decreased. So this can actually help in morbid patients or patients who are really morbidly obese. And but there are very few studies at present, so the evidence is not that robust for us to opt for it. But nevertheless, CO2 is one of the gases which will actually increase the respiratory rate. It will sensitize the respiratory centers so that the patient would be able to breathe much better. This is one of the slides which I'm taking from a thyroid case, where if you look at the thyroid the after thyroidectomy, we have tried to do an ultrasound to see if there is a vocal cord palsy or not. I have the video, but just let me show you the picture. So this patient, when we looked at her post-operatively, we found that one side of the cord is actually paralyzed. And during abduction and adduction, the paralyzed cord remained stationary, but it was the other functional cord which was able to compensate for the movements of the contralateral side cord which was paralyzed. So even if this occurs during extubation, the reason I'm trying to show the slide is that instead of doing a laryngoscopy after extubation in thyroid surgery to detect whether the vocal cord movements are present or there is paresis or palsy, which actually puts the patient into a great danger where the hemodynamic responses are acute. And contrary to the induction, where more than 10,000 articles are available, where we talk about suppression of hemodynamic pressure response to laryngoscopy and intubation, all that knowledge and papers vaporize when we do extubation in such patients. The patient's neuromuscular blockade has been reversed. Patient is awake, and we try to put in a laryngoscope, almost doing an awake laryngoscopy. The BP shoots up, and we get only a fraction of a second or 2 seconds to see the cords and to record that, yes, there is a palsy or not. I think this practice should be stopped, because if you want hemodynamic responses to be suppressed in any of the cases, it applies equally to the extubation process. It's not only confined to intubation. So remember that this time, when you do it, there are better methods which are non-invasive, like ultrasound, which can detect the mobility of the cords, and which is easily done in the front of the neck without endangering the patient with that kind of stress response to laryngoscopy, which is only going to be a recording, or you are going to just write down. Even if the patient has palsy, nothing is going to be done about it. It is just going to be recorded. So it's just to satisfy the surgeon and ourselves that there is paresis, and normally this is a temporary paresis, and it should recover unless it's a carcinoma where the vocal cords have been paralyzed right from the beginning. And if you would have done an ideal, you would know that these paresis would exist post-operatively. Hopefully that the other cord is also not paralyzed. You would like to know that. But anyway, once the tube is removed, if the patient has stridor, then there's no point in looking at the cords. You need to put back the tube in. So looking at it through a laryngoscope just to look at the movement of the cords is not justified, ethically not justified. Now let's go to the other part of the 3S, which is a leak test, which is talked about a lot. And as per the survey which we had done, not many of us practice it. Nevertheless, I think it is essential that all of us know how leak test can be done. So leak test can be qualitative or it can be quantitative. If you're doing a qualitative leak test, it can be done in a patient who is paralyzed and who is on mechanical ventilation. In that case, what you will like to do is that you will have to measure the air, at least record the airway pressures and the tidal volume, which should be the same as it was during intubation. And then when you deflate the cuff, you should either be able to hear an audible or a palpable leak during inspiration. So when the ventilator delivers the inspiration, if you hear an audible leak, that means there is leak test is positive. But if you are not able to get an audible leak, if you place your hands in front of the, onto the larynx, onto the cervical trachea, and if you are able to perceive that there is leak there, then again the leak test is positive. That means there is leak around the cuff when you deflate. In spontaneously breathing patients, if it is a qualitative analysis, you will have to deflate the tracheal cuff, disconnect the ventilator tubing from the endotracheal tube, occlude the endotracheal tube with a finger, and monitor for leak, because now the patient is spontaneously breathing. You can again have an audible leak, a palpable leak, or at the most you can also do a auscultatory leak, whether the air is coming, having an egress outside the larynx by the side of the tube, so that there is a peritubal leak. So these are qualitative leak tests which can be done readily.
There is no voice.
हॅलो
Hello.
हा सर नेटवर्क प्रॉब्लेम आहे सरांचा
So, sir का problem आया क्या?
यस यस यस
Sir has exited, I think so.
Huh?
Sir has exited, I think so, because of the network issue. I think he will be joining back.
He'll be joining back.
Sir will take few seconds to connect back. He is trying.
Okay.
Okay. Rajulkar sir, you have anything to say?
No, I have actually told about this extubation importance. We give much importance to the intubation, but extubation is neglected. But whatever I have read last 2 days is very alarming. Extubation complications are very alarming, especially head neck surgeries, thyroid surgeries. And one must know these strategies, these guidelines developed by Difficult Airway Society and ASS Society. We should follow. Now, as sir has said, leak test, I have read about this test, but till now we have not performed this leak test. But this test is very efficient. Whatever I know about this test, we should perform. At least we should try to test in every patient, so that we develop that habit of testing this leak test. And this leak test means, suppose there is a long, sir has come back. Is he here?
Join. I can see him.
Yeah. Okay.
I'm sorry, sir. I got disconnected from the internet, so I've just taken a hotspot. Sorry for this. Sorry for this. What has happened? Are you able to see? I don't think so.
Mm,
Yeah.
We
You're able
can
to see?
Yes,
You're
yes,
able to see the slide, sir?
Yes, sir.
Yes.
We can see the slide.
yes, yes.
But it's not full screen, sir.
Yeah, full screen. It is now in full screen. Are you able to see it?
Now we
Yeah.
can see, sir. Yes.
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 So I think I got disconnected here, right?
Yeah, for
Yes.
just a short while, sir.
So when we talk about quantitative leak test, it has to be done under controlled ventilation. So what we need to do is that the patient should be on volume control and there should be neuromuscular paralysis. And then you have to take the expired tidal volume measurements. So once you deflate the cuff, you will have to look at how much of the volume is being lost. If it is less than 10 to 25% or 110 to 130 ml, then it is positive. So it is indicative if it is if that much amount of leakage is not there, there's probably airway edema or airway collapsibility. Now just remember that this leak test is not always going to predict the outcome. So leak test, when there is an airway collapse, in static conditions, it may reveal that there is a leak. But when you remove the tube and patient starts breathing in, especially during inspiration, the airway will collapse. So it's a dynamic obstruction rather than a static obstruction, which you are going to observe when there is in a leak test, especially when there is the airway collapse like tracheomalacia if it occurs. So those are the issues where you need to detect the airway tracheomalacia intraoperatively, talk to the surgeons, how are the cartilages affected, how is the trachea, whether it is holding back its shape. At that time, you have to deflate the cuff and see whether the trachea is holding its shape or it is going down. So that judgment can be done intraoperatively for you to know that what is going to be the outcome when you take out the tube. So the static tests like this for leak test, especially for cervical trachea, may be misleading at times. You may get some leak and you may think it is all right to take out the tube. But if there is a suspicion, it's always better to be on the safe side, put in an ASC, and then over an ASC, you take out the tube and then see if the patient is able to maintain or not. Because under dynamic conditions, when the patient exerts an inspiratory pressure, the airway may collapse, which may not be so when you are doing it under static conditions. So this is another way you can do it. This is an airway ultrasound. And what I'm trying to show you is that in the left image, let me use the pointer. So in the left image, you find that once the cuff is inflated, the air column width is almost rectangular. And when you deflate the cuff, the air column width becomes trapezoid. So there is peritubal leak now, and this air column width has widened. So this tells us that there is a peritubal leak, which should be satisfactory. This is also done in adults, where the same thing which I'm trying to show you, that the air column is generally rectangular in shape. And when you deflate the balloon, it becomes trapezoid and the arytenoids are masked by the air column. But more important than that is this figure. Now, this is the figure when I inflated the balloon. And when I deflate the balloon at the same time when I do a transfer scan, this image remains the same. There is no change in the image at all. If this happens, then there is a very high likelihood that you may end up with some sort of a stridor or airway compromise after extubation. Now let's move on to some other conditions, especially dentistry. So this is where you do an interdental wiring because the patient has the fracture of the mandible and maxilla. They want to fix it up. And before extubation, with the tube inside, they're doing the interdental wiring. And then they say that you need to remove the tube. And the only option at that time we would have is to go for a tracheostomy. But there is an alternative, which is called as a submental diversion. So how do you do it? Just at the middle of the angle of the ramus of the mandible, the dental surgeon or the facial maxillary surgeon can make an incision. The artery forceps forceps comes below the below the tongue, and then you can catch the proximal end of the tube, right, and direct it to the opening through the artery forceps, which is catching it, so that the whole tube or the proximal part of the tube is not coming out of the mouth, is confined inside the mouth. And because it's a reinforced tube, the acute curve which the tube takes, it doesn't allow it to kink. So there will be an acute curve from the larynx for it to come out through the opening which has been made. And this is termed as submental diversion. So you can avoid tracheostomy and maintain the patient on this submental diversion till the patient is fully awake, and then take out the tube and close the skin by the stitches. The advantage is you don't damage the tracheal cartilages for a tracheostomy, and this is a little lesser invasive procedure than a tracheostomy would be. So these are the options for interdental wiring when they need the tube to be out, and before extubation you need to maintain the airway till the patient is fully awake and safe. Now, the other aspect is airway edema, which we encounter very frequently. Now, the problem is with the tube, when it is inside the trachea, how would you make sure that the upper airway edema subsides? Because whatever you give through the tube is going to go below the trachea into the lungs. It's not going to come up to the larynx to make sure that the edema subsides. Even if you start giving steroids, it's going to take about 12 to 24 hours before some sort of edema recession takes place. So the solution to this is that you change the tube to an LMA in case you wish to do so. And then through the LMA, you can maintain the airway. This is a ProSeal, and with a T-piece connector, you nebulize epinephrine. So once you nebulize epinephrine, the whole epinephrine with the fresh gas flow from the circuit would be directed towards the larynx or towards the arytenoids and all other structures which are supposed to be edematous. And this will provide immediate relief because epinephrine acts locally there. Now, can we do that without removing the tube? So this is another figure which I'm going to show you. This is the endotracheal tube which is in place, which is connected to the anesthesia circuit. So I have passed another tube which is 6.5 millimeters just by the side of this tube for it to be placed in the pharynx. So when this 6.5 millimeter internal diameter tube is placed in the oropharynx, you attach a Hudson's nebulizer here. And again, you can nebulize epinephrine so that the entire epinephrine is nebulized and directed towards the larynx to reduce the edema. So by doing these maneuvers, it's much faster to get the edema reduced, and maybe the extubation time can also be reduced in case there is a upper airway edema which you are anticipating. Especially when you had multiple attempts to intubation, multiple laryngoscopies, you will expect that there would be edema there, and you might have given steroid, but local nebulized epinephrine is the best way to treat such patients. Now, coming to the other part, which now most of you would be handling, is obesity. This is where I have taken the left limb and the middle limb, where I have 4 Ds, that is difficult mask ventilation, there may be difficult intubation, delayed recovery, and difficulty because of pre-existing disease. So this is a patient who had some difficulty during intubation and now have to extubate. So this is the position which was given to the patient for extubation. Now my request is to all of you that remember that this patient may require intubation again if you lose the airway. So the extubation should also be done in a similar HELP position to optimize the airway and then take out the tube so that your mask ventilation becomes easier. Give a head up tilt of about 20 degrees so that the entire abdominal pressure is removed. The patient will have increased pleural pressures and esophageal pressures, which may actually cause some sort of airway compromise. Therefore, if you have to give some PEEP, some sort of an IV in between, make sure the patient is placed in a help position when you extubate, and make sure you have a difficult cart ready with you to handle the patient in case you are facing a problem. Now, how to ensure complete recovery? Because extubation is an end process, and whatever has been done in between to manage anesthesia will play a major role how successful your extubation is going to be in a difficult case. So the anesthetic techniques significantly influences the process of extubation. So if you look at the anesthetic technique, there are a lot of ERAS protocols which have been published. Our team has published almost 6 or 7 of them. And what we find is that your preparation for this ERAS protocol to have a rapid recovery and good recovery of the patient is important, and it starts from pre-medication. Prokinetics should be given. Drugs for comorbidities should be continued, but avoid sedative drugs, because these sedative drugs may contribute to postoperative drowsiness. General anesthesia plus regional anesthetic technique is good. If you want to place an epidural, do that before induction, because for your epidurals to work well, there should not be any somatosensory or visceral input. If there is 2-segment input from the visceral segments, then your requirement for general anesthesia would be more. So place the epidural, see what is the segmental block which you have achieved. And once you know that this volume has blocked the entire area which you want to block for no nociceptive stimulus to go to the patient, then you start inducing the patient so that you can do mostly under an epidural and just complement patient sedation with least amount of neuromuscular blockade and without narcotics to get the patient out. So continuous analgesia can be done by catheters. You can use sevoflurane with minimum MAC and avoid opioids, because once your regional is acting, you would really not require opioids at all. Now comes the action of neuromuscular blockers. And if you ask me frankly, these are the drugs which are widely abused during general anesthesia. And they are the cornerstones around which the patient's recovery and how they behave postoperatively depends. So neuromuscular monitoring is one of the gadgets probably all of us should invest in. It doesn't cost much. It costs much less than spending for a dinner for about 4 people. So if you can have this neuromuscular monitoring with you, things would be very objective, and you would know what to do with antagonizing them. So remember, the cholinesterases which you use to antagonize the neuromuscular blockade or the residual neuromuscular blockade cannot be the same fixed milligram dosage for all patients. It varies. So the principles of pharmacological reversal is that Tiva does not enhance the neuromuscular blocking drugs effects, and you should have a minimal count of 2 before you start the reversal. Volatiles do enhance, but when you give smaller amount of MAC, like 0.5 MAC with an epidurals, you really do not have to bother about it. And once you get a TOF of 4 count, then you can give your the anticholinesterase. But the TOF should be 0.9 quantitatively. And if it is 0.9, then you should not give neostigmine. The reason is, if you give neostigmine after full neuromuscular recovery, it decreases the upper airway muscle activity and tidal volume. So you're doing more harm to the patient if the patient is already completely recovered. Neuromuscular monitoring, if you have a count of 1, you should delay reversal, wait for the second and the third count to come, and then administer the pharmacological reversal. And the TOF with fade, if it is less than 0.4, then you can go ahead and administer pharmacological reversal. But if there is no perceived fade, TOF is 0.4 to 0.9, then administer low dose of neostigmine of 20 mics per kg. So this is how objectively we should be using anticholinesterases, and I'm dead sure none of us are doing that. So my request to all of you is, that please invest in neuromuscular monitoring. This is one of the safe ways of making sure that this component of residual neuromuscular blockade or new stigmine is not adding to the complications or not complicating the matters which you're likely to face. Now, the extubation process, how should it be? The patient should be fully awake and obeying commands. Attenuation of emergence phenomena should be done. And what we normally use is either intravenous lignocaine, just as you use for intubation, or the best way is, and I emphasize, the best way is inflate the tracheal cuff with 4% lignocaine instead of air. And the tube tolerance and attenuation of emergence response is extremely good. The patient would be awake without bucking on the tube and getting a blood pressure above 200. Bailey's maneuver is a good choice, but it requires a lot of experience. Yes, you can go ahead. I'm not against it. But then remember, the supraglottic devices only produce a soft seal. So if you're having an obese patient where the soft seal is going to break at about 20 centimeters or maybe 25, then you would not be able to perform the recruitment maneuver effectively. So I'm just going to show you the video of how after inserting, after putting a 4% lignocaine, we were able to do this. So this patient is fully awake. He's not bucking at the tube. And let him breathe spontaneously. And if you look at his parameters here, the BP is 131 by 69. Heart rate is 87, and he's fully awake. There's no stress at all onto the patient. All these parameters are normal. And you see the EtCO2, it is about 37. And you slowly take out the tube, and the patient is fully comfortable and has no issues at all. So such kind of maneuvers are extremely helpful. Now, to emphasize on intracuff lignocaine, there are a lot of meta-analysis which has been done, and there are results of 19 trials which comprises of about 1,566 patients, and they say that the incidence of post and emergence phenomena is decreased significantly in lignocaine groups as compared to control groups. So these are this is the evidence which we have, and I feel that it should be one of the ways of managing the patients. Even in some of the patients where you want to use IV lignocaine versus 4% lignocaine, I think 4% lignocaine scores over the IV lignocaine. It works really well. So give 4%, inflate the cuff, and it just desensitizes the area where the cuff is in touch with the tracheal mucosa. What about reintubation? At times you require reintubation. There are ways to do it. And I would recommend you to read the second article by Dr. Dhara, where he's pointed about development of a new system of guide wire assisted tracheal intubation and mannequin. So this guide wire is actually there is a channel within the reinforced tube through which the guide wire can go. So when your AEC is not within the tube, you have the whole lumen available for you to continue to give oxygen to the patient while you also have the guide wire in place before you remove the tube. So that's the beauty about this. And remember, there are issues with bougie-guided intubations and also extubations because the physical properties of the endotracheal tube and the bougies as regard the rigidity and elasticity are not the same, and they are not standardized. So the rigidity would increase with increasing endotracheal tube size, and the stiffness will decline as soon as these guides are exposed to the body temperature, and then you would have difficulty in reintubating, and you may cause a lot of trauma or failures. So this is one study which we did on the bench side to see how the McEnroe tracheal tubes and the tracheal tube introducers were seen. And you'll find that the device stiffness which we measured with this device actually changes so much with temperature if you look at these temperature changes, 17 and the room temperature of 37. So there's such a remarkable change in that it's the results would not be same. Let's say 6.5 millimeter tube. At 17 degrees, the device stiffness is about 13.8 grams per millimeter. But when you change the temperature to 37.5, it is just 7.1. So it was consistently observed that the device stiffness of your introducers varies with temperature. And when you keep that inside for 2 hours or 1 hour, your intubation might fail when you want to railroad the tube over it. So what he had, Dr. Dhara had devised is a tube like this. So this has a separate channel which is embedded within the endotracheal tube material, and it is within the wall of the endotracheal tube. And you can safely pass the guide wire through this. So what happens is this lumen is completely exposed for you. There's no introducer inside, so you can attach oxygen as much time as you want to, and still you have the guide wire there before you remove the tube. But if you have an introducer here, you will not be able to give oxygen through that. Giving oxygen through the devices which have a channel is dangerous because it produces a jet there. And producing a jet at that particular point can actually be very harmful inside the lungs. So this is how the distal end looks, and this is how the proximal end looks. So my summary is that we are in process of revising the 2016 extubation guidelines, the Indian guidelines. Extubation in head and neck surgeries, there are benefits of immediate extubation. So just don't delay extubation. Just because you think there can be a problem, let's overnight ventilate. The medical problems can actually exaggerate in such patients if you are really keeping the tube even for 12 hours. Planned tracheostomy or upfront tracheostomy in advanced cancers is a good choice. Extubation in children would be talked about later. Extubation in obese, follow the ERAS protocol. Early recovery and neuromuscular monitoring is a must. Thank you very much for your patient hearing. And I'm sorry I got disconnected and I could not connect for some time. Sorry for that disruption and if I've taken some extra time. Thank you so much.
Thank you, sir. Thank you, sir, very much. We are actually very privileged of hearing from you, sir. Sir is actually has.
If there are any questions, I would be very happy to answer.
Yeah, yes, sir. We have actually 3 questions in the chat box. The first question is, sir, what is the dose of adrenaline nebulization?
Actually, what you need to, yes, sir. So actually what you need to do is you take epinephrine, take 1 milligram of epinephrine, put it in a Hudson nebulizer and put 5 ml of saline. That should be good enough to nebulize epinephrine towards the upper airway. What is the dose of intracuff lignocaine? The dose of intracuff lignocaine is that you keep giving intracuff lignocaine till there is no leak. So keep a hand over the trachea while ventilation is being done. Keep injecting. Once you know that the leak has stopped, that there is no leak, stop injecting that, and that should be it. And at the end, you will find that almost the entire amount of lignocaine which you had actually injected, you are able to aspirate it out. So it goes that barrier of the cuff is very minimal for that to go, but it effectively desensitizes the area. But just remember one thing: one of the studies is going to come up probably in the next issue of IJA. We did that in children. And we found that the efficacy of intracuff lignocaine happens only if the surgery lasts for more than 1 hour. Right? Before 1 hour, probably the time is too less for it to diffuse out in small quantities to cause desensitization area at which the cuffs are in contact. But if you add bicarb to lignocaine, then it can be used for less than 1 hour surgeries, because that enhances the diffusion and probably it will happen faster than when you only give lignocaine 2% or 4% into the cuff.
Sir, thank you, sir, for your elaborate lecture on various aspects of extubation. and application of ultrasound and neuromuscular NMBs. I have one question. How do you think about awake extubation against deep extubation?
Thank you, sir, for asking this question. In about 35 years of my practice now, I have rarely used deep extubation, except in bronchoscopies. That also in children, because when they remove the rigid bronchoscope, the patient is at a deeper level, and then you have no option that you either maintain the patient with face mask or you put in the tube. Most, apart from the laryngeal surgeries, which may require to suppress the responses and the patient's responses can be exaggerated, I have never used deep extubation in my patients. I always make sure they are fully awake, the residual neuromuscular blockade is properly antagonized, and they obey commands before I take out the tube. That's my practice, and I believe that should be the practice we should do.
Thank you. Any more questions before we go to another lecture?
There are no questions. Yeah. Thank you, sir. Thank you very much, sir.
Thank you, sir. Sir, I'll take your leave because I have another meeting online to be joined. So thank you very much. Kindly give me permission to leave this webinar, sir.
Thank you very much, sir.
Thank you, ma'am. So there's another question. They said during our residency, there was a practice to spraying 4%. Now, this is a relevant question, an important one. With the permission of the chairman, can I, sir, I answer this?
Sir,
Yes,
please,
go ahead.
please.
Yeah, so see, the problem here is that if you spray and remove, you are going to cause desensitization of the areas which are responsible to prevent aspiration. So below the cords, it's fine. But above the cords, if there is a spray, then there is going to be a problem as far as aspiration and secretions are there, because the patient's ability to cough will be lost. So that's one inherent problem of spraying before removing the tube. But intracuff doesn't inhibit cough response. The patient will still be able to cough because anything above the glottis will stimulate a cough reflex, and he will be able to generate the cough because he's able to approximate the cords well and create that negative pressure to cough out the secretions. But if you are going to spray, that ability to approximate the cords and generate an effective cough would be lost, and the patient can aspirate just like you do for your fiber optic intubation. You anesthetize that area and the patient's responses are reduced. So let us not do that during extubation, because that will endanger aspiration and other complications thereafter. Thank you, sir.
Thank you, sir. Thank you, sir. So our next lecture is by senior pediatric anesthesiologist from Nagpur, Dr. Deepali Mandlik, and she will talk on intubation and extubation challenges in pediatric patients. So friends, as we all know that children are not small adults, and there are certain attributes unique to the care of children, and like variations in anatomy, physiology, which makes intubation and extubation challenging in these categories of patients. So let us hear from Madam the various problems faced by us during intubation and extubation in pediatric patients. Madam, please.
Yes. Thank you, Rajurkar sir. Good evening, everybody. At the outset, I would like to thank ISA NCB and SAMS for inviting me for this on this forum. Okay, so today I'm going to speak on intubation and extubation challenges in pediatric patients. This is not going forward.
Just click on the slide, ma'am. It will start moving.
Click on the slide.
Yeah.
Yeah. Okay. So actually, intubation and extubation are actually really challenging for the anesthesiologist. and more so for the occasional pediatric anesthesiologist for whom it might be a little scary when a small baby is brought in front of him. So a good knowledge about the anatomy and physiology of the airway would be helpful in the proper management of the pediatric airway. Children are at an increased risk for airway complications. The American Society of Anesthesiologists and the Pediatric Perioperative Cardiac Arrest Registry has said that brain death in pediatric patients are still mainly caused by airway problems. Okay. Now, the reasons for this can be both anatomical and physiological. Let's see the anatomical factors. Children have a large head relative to body size. They have a large tongue. The epiglottis is large, leaf-like. It's likely to obstruct the view of the vocal cords. The larynx is positioned higher in the neck, C2 in infants, C3, 4 in children, and in adults it is at C6. The laryngeal and tracheal cartilages are soft and easily compressed. Now, what happens because of all this? All these factors predispose to obstruction if the head flexes forward and the child loses consciousness. Now, all these anatomical characteristics are more pronounced in children less than 2 years and even more so in neonates. So, as a child grows older, these they become more and more adult-like. So, placing a small roll towel beneath the shoulders will help to open the airway. It will bring the oral, pharyngeal, and laryngeal axis in a straight line and will open the airway. So it is said that actually the ear lobes and the sternal notch should be in one line in a small child. Now, care should also be taken not to flex the baby's head during lateral positioning for spinal or caudal or epidural, because this is what happens. The anesthetist is concentrating on the spinal or the caudal, and the assistant tends to flex the baby's head, tries to flex the baby as a whole. So this is a diagram of where in figure A, you can see the large tongue which is obstructing the airway. The head is so big, the tongue is so large. So even if the baby lies supine, the head and the tongue themselves tend to obstruct the airway. Whereas in figure B, the shoulder roll is kept below the shoulder and that opens out the airway. The larynx is funnel shaped in small children, narrower in the subglottic region, which predisposes the child to greater risk from intubation trauma. The larynx and trachea are so small that even minimal swelling can cause obstruction. So in an adult, if there is a 1 millimeter edema, that will cause a 44% decrease in the area, whereas in an infant, even a 1 millimeter edema will cause 75% decrease and 16 times more resistance to airflow. In older children, there may be tonsils, adenoids, so obstructive sleep apnea, difficult mask ventilation, and intubation. This is a diagram showing in an adult, the larynx is cylindrical shaped, whereas in the infant, it is more funnel shaped. This figure 6 shows the difference in edema if in an adult and in an infant. See, in an infant, even a 1 millimeter edema can cause the obstruction. There are physiological changes also. Infants have only 10% of the number of alveoli as adults, and so they have less area for gas exchange. FRC is less than an adult. Dead space is higher than in an adult. So there is a lot of wasted ventilation. The higher metabolic rate and higher oxygen consumption and CO2 production. To compensate for this, infants have a higher respiratory rate and a higher heart rate. So all this actually gives less apnea time for hypoxia. Again, because of the more horizontal angulation of the rib cage, there is less expansion of the chest wall. Babies rather, are mainly belly breathers. So abdomen expands as the diaphragm descends. So in case of abdominal distension because of any cause, so say intestinal obstruction, there may be impaired breathing. The chest wall is more compliant in children because of lack of rib cage ossification. So in any restrictive or obstructive disease of the lung, there is indrawing of the chest and less air entry. As the tidal volume cannot be increased, that is compensated by an increase in the respiratory rate. The child's nervous system is also immature. Parasympathetic nervous system is better developed than the sympathetic. And so bradycardia is the first sign of hypoxia and not the last. So the compensatory tachycardia that is seen in adults is not seen in babies, in neonates and younger, smaller infants. Bradycardia will cause decreased cardiac output, decreased oxygen delivery, and further hypoxia, hypercarbia, acidosis, and arrest. Nerve myelination is incomplete and the blood-brain barrier is poorly developed, so they get easily over-sedated, which can again cause respiratory depression and apnea, even with smaller doses. There is altered control of ventilation, periodic breathing and apnea can be seen up to 60 weeks of post-conceptual age. Children are uncooperative due to fear. There are psychological factors also. So because of this, pre-oxygenation is not possible, may not be possible many times, most of the times. Physical struggling again increases the metabolic rate and oxygen consumption, but oxygen delivery is not improved. Crying again causes increased airway irritability, increased secretions, and many children most of the times have URTI, which again increases the work of breathing. This is a diagram showing the immature sympathetic system and its effects. Okay, so preoperative airway assessment. How will you decide that this airway may be difficult? You have to ask for, you have to look for history of abnormal cry or hoarseness of voice, history of snoring or sleeping in a prone or semi-prone position, obesity, often with short neck, double chin, history of URI, asthma, bronchitis, hyperreactive airways. Then there may be congenital facial anomalies, facial asymmetry, hypoplastic chin, micrognathia, retrognathia, macroglossia. They can be associated with many craniofacial syndromes like Pierre-Robin, Streeter-Collins, Klippel-Feil, and many others. There may be previous trauma or burns of the head and neck. There may be a neck mass like cystic hygroma, previous surgery, radiotherapy of the head and neck, previous documentation of difficult airway. So all these things have to be asked for. Now, there are many measurements described which help to identify possible anatomical abnormalities. These are all the measurements. Most of the times we use lower lip to chin distance and thyromental distance. There is Malampatti is of no use in pediatrics. They will not open their mouth. And there is also a Cooper index, Colorado Pediatric Airway Score, that is also being used to identify the airway equipment. Now, this can be remembered with a simple mnemonic called SOAP-ME, which means suction, proper size catheters, oxygen, airway devices like masks, airways, laryngoscope blades of different sizes. If you have advanced airway devices like video laryngoscope, supraglottic airways, Stilett, fiber optic bronchoscope. Positioning, a shoulder roll should be available. All the drugs should be in the proper calculated doses. Monitors, the routine monitors. Equipment like defibrillator, cricothyroidotomy, tracheostomy set for front of neck access. Now, in a child or in children, it's never a one size fits all. So the mask and your mask size has to be appropriate. The mask fit has to be good. Then if you're using oropharyngeal or nasopharyngeal airways, they also should be of the correct size. So how do you see the size of oropharyngeal airway? It is measured from the corner of the mouth to the angle of the mandible. Now you have to use nasopharyngeal airways very cautiously because children may have adenoids. And so the nasopharyngeal airway can itself get plugged with adenoid tissue, which can again get aspirated, and there may be trauma, bleeding. The correct size of a nasopharyngeal airway is measured from the nostril to the angle of the mandible. If it is too large, it may cause blanching or ischemic compression of the nostril. So while measuring the size of the nasopharyngeal airway, you should never consider your little finger or see the outer size of the nostril, because there may be inside the passages may become narrower. If a nasal airway is not available, you can cut the endotracheal tube to appropriate size with the bevel in the posterior pharynx. Now, nasopharyngeal airways can also be used to deepen the level of anesthesia. It can also be used to give IPPV with along with an inhalation or other agents. And this is a trolley, say, with all sides of masks and airways and laryngoscopes. Laryngoscope, a pediatric handle, is used. Straight blades, usually Miller straight blade is preferred to curved. These are the sizes, various sizes which have been described. Size of the blade, the endotracheal tube, uncuffed and cuffed. Length of the tube. Usually neonates, it is weight in kg plus 6, or also the 7, 8, 9 formula. So 1 kg is 7 centimeters, 8 kg is, 2 kg is 8 centimeters, and 3 kg is 9 centimeters at the lip. Or for below 2 years, it can be size of the tube multiplied by 3. Cuffed versus uncuffed endotracheal tubes. So this was quite a hot topic for debate till recently. Now, low pressure microcuff tubes are available can be used even from neonates. They are available even from size 3 or 3.5. Advantages are they protect better against aspiration. They avoid multiple tube changes. They will give a more accurate tidal volume and with more precise monitoring of ventilation and less OT pollution from leakage of gases. Disadvantages are that cuffs take up space, and so a smaller size tube will have to be inserted, which again will cause greater resistance to breathing. Again, smaller lumen may cause increased risk of blockages, and also it is more expensive. Now, is there any modification to be done in the procedure of intubation? Because the larynx is located higher in the neck, so you're using a straight blade which can directly lift up the epiglottis. In older children or in adults, you use a curved blade which is actually inserted in the vallecula, which indirectly lifts up the epiglottis. Whereas in smaller children, you're using a Miller blade which can actually directly lift up the epiglottis. In smaller children, the curved blade may actually fold the epiglottis down to block the view of the cords. Again, position for intubation is raising the shoulders by keeping a roll towel under the shoulders. This is a diagram which shows how a curved blade acts and how a straight Miller blade will lift up the epiglottis. Now, misplacement of the endotracheal tube can very easily occur, especially in neonates. So the optimal placement of the tube will have to be verified every time the child is repositioned. Neonates, the difference between intubation and extubation can be just 1 centimeter. Cricoid pressure has to be very light. In a neonate or infant should be with only 1 finger, and with toddlers, even toddlers, 2 fingers. And many times the person who is intubating himself can give cricoid pressure, holding the laryngoscope with 3 fingers and using your little finger or your ring finger to give cricoid pressure. Laryngeal mask airway can be used for shorter duration surgery or also as a rescue airway, and even small LMAs or small even IGLs are available now. Rapid sequence intubation. So the classic rapid sequence intubation is difficult in children because it's very difficult to give cricoid pressure. The cricoid cartilage is very soft, and giving cricoid pressure itself might displace the esophagus, causing aspiration rather than preventing it. Again, you cannot keep the child apneic. The classical RSI, you give relaxant, give cricoid pressure and do not ventilate. But that may not be possible in a child. So you use what is known as controlled RSI. So pre-oxygenation as much as possible, give a good RT suctioning and gentle bag mask ventilation. Use a short-acting muscle relaxant. Use a good depth of anesthesia and a short-acting muscle relaxant for intubation. Anyway, actually in children, you must always do a gentle bag mask ventilation, because a high pressure bag mask ventilation will push air into the stomach and cause stomach distension. Also, a gentle bag mask ventilation should also be done in neonates with tracheoesophageal fistula or congenital diaphragmatic hernia, because you cannot allow the air to go into the stomach. Then these are algorithms for difficult mask ventilation. I think Dr. Kundra sir has dealt extensively into all these algorithms. I'm not sure whether I should really go into the detail. Then this is algorithm for unanticipated tracheal, difficult tracheal intubation. So then this is a CICV, cannot intubate, cannot ventilate algorithm. So the principles of difficult airway management would be that oxygenation and not intubation is life-saving. If you find that there is a difficulty in either mask ventilation or intubation, just call for help immediately. Don't keep on trying, don't keep on attempting to intubate. Limit the number of direct laryngoscopy attempts and proceed to more advanced devices sooner than later. Always have a supraglottic airway as a rescue device, and passive oxygenation is a must. This is all about intubation. Now, I would like to go to challenges of extubation. But actually, really, I mean, Kundra sir has dealt so extensively with all this that I think I'll just give a quick overview. So, extubation is a critical moment as children are prone to respiratory adverse events. Adequate suctioning has to be done before extubation. Small babies cannot understand voice commands, so breathing patterns and SpO2 have to be observed. Extubation can be deep or awake, depending on the patient's clinical profile and the anesthesiologist's experience and protocol. So how do you do an awake extubation? So for an awake extubation, child should have adequate tidal volume and respiratory rate. Conjugate gaze should be there. Eye opening should be there. Adequate muscle tone should be there. Pulse the saturation has to be maintained above 97%. And the end-tidal inhalational anesthetics have to be at a minimal. So what are the indications for a awake extubation? Difficult bag mask ventilation or difficult intubation, when there is a high risk of aspiration, and when the child is at a risk of inadequate ventilation after extubation. Example, a preterm infant or small babies less than 2 kg, or in an obese child or a child with obstructed sleep apnea. So what are the disadvantages of awake extubation? There is increased risk of coughing. Increase in the airway pressure causes increase in the intracranial intraocular pressure and may cause risk of bleeding and injury to the surgical sites. Now, this is especially problematic in neurosurgery, ENT, and plastic surgeries. Now, to reduce coughing, you can give IV Dexmed or midazolam or fentanyl. Deep extubation. In this, the only criteria is that the child should have an adequate tidal volume and respiratory rate. So what are the indications for deep extubation? Patients with reactive airways, asthma, acute URTIs, you would like to extubate deep. The advantages, there is reduced cough reflex and bronchospasm. But in a deep extubation, there may be increased possibility of airway obstruction. And so you have to keep everything ready for intubation. Now, this again, sir has already mentioned, extubation is classified as low risk in ASA 1 and 2 patients or with uncomplicated surgeries. Intermediate risk, where there may be compromised airway or impaired respiratory efforts after extubation, but bag mask ventilation or intubation may not be difficult. Example, in a patient with lung pathology, congenital heart disease, pulmonary hypertension, OSA, any neuromuscular disorders, or altered mental status. And high risk, where re-establishing the airway may be difficult or impossible in a known case of difficult airway. So in intermediate and high risk cases, it is better not to extubate in the immediate postoperative period. Now, problems with extubation, problems that can occur with extubation. Laryngospasm. So incidence of laryngospasm during anesthesia is higher in children. In children between 3 to 9 months, it is twice as that as adults. And in infants 0 to 3 months, it is 3 times that of adults. More common in children with obstructive lung disease and URTIs. Causes is lighter plane of anesthesia, secretions, blood, mucus, or laryngoscope, which can stimulate the vocal cords. Prime times are during intubation and immediately after extubation. Prevention is don't extubate when the child is actively coughing, keep the airway clear of secretions, and use a muscle relaxant for intubation. Treatment, it has to be recognized and managed quickly to prevent hypoxia, bradycardia. So ask for help. Suction the airway to stop stimulation of vocal cords. Give CPAP with mask with 100% oxygen while giving jaw thrust. So the jaw thrust lifts the epiglottis and the tongue off the glottic opening and creates a gap between the cords. Now the CPAP further forces oxygen between the cords and forcing the cords further apart, breaking the spasm. If that doesn't break the spasm, you can deepen the anesthesia with propofol. And even if that doesn't break the spasm, you can give scoline, succinylcholine, 0.5 to 1 milligram per kg IV or 3 to 4 milligram per kg IM. And the patient will require some ventilatory assistance. Now, there are some other things have been reported also with some success to treat laryngospasm. One is Larson's maneuver, that is applying bilateral firm pressure over the styloid process behind posterior ramus of mandible while pulling the mandible forward. So that gives a painful stimulus to open the cords, and with CPAP, it has been said to break laryngospasm. Other methods like gentle chest compressions have also been reported. Bronchospasm. So again, the patients with reactive airway disease are more at risk for this. Risk increases at emergence when the endotracheal tube is in situ and the depth of anesthesia is reduced. Treatment is beta agonist, adrenaline nebulization, steroids. Then post-extubation stridor. Causes are upper airway edema, vocal cord dysfunction or paralysis, and laryngospasm. Risk factors are traumatic intubation or extubation, a tight-fitting tube, coughing on the tube, frequent manipulations of the tube during head and neck surgery. Management is just warm humidified oxygen and nebulized adrenaline and steroids. Negative pressure pulmonary edema. This occurs when the child attempts to make a deep inspiratory effort against the glottis. Example, a child is biting the endotracheal tube or when there is laryngospasm. That usually resolves within 24 hours with minimal or no sequelae, and treatment is removing the obstruction, oxygen supplementation, and observation. Diuretics and CPAP or both may help to expedite the treatment. So this was a small overview about intubation and extubation. I stuck to the basics actually. And induction and awakening from anesthesia has actually been likened to an aircraft or a flight taking off and landing. So the better we know about the characteristics of the anatomy and physiology in children, the smoother the journey will be. So these are my references, and thank you.
Thank you, ma'am. Thank you very much.
Thanks, Deepali, for your brief but exhaustive enlightenment on this intubation and extubation in pediatric neonates. How about intubating these P-Robin patients? Any technique? Any special technique?
Special technique is, see, Pierre-Robin syndrome will have micrognathia, a large tongue, and a cleft palate. So the mask ventilation may be difficult, even intubation may be difficult. So for the mask ventilation, that is what you try the jaw thrust, put a shoulder roll, and with that also, if it is not possible, then you can put a maybe airway, which will open up the put a oropharyngeal airway, which might open up the airway, or you might put a nasopharyngeal airway.
You're right.
Thank you, Pali, for an excellent talk.
Thank you, Deepali. Thanks. No more questions, I think.
Yeah. Can I request everyone to just switch on their camera so we can take a group photograph?
Thank you, Rajurkar sir,
Thanks. Thanks, Gauri.
for sharing your insight.
Thanks.
Any more questions we are having?
I don't think
No, there are no questions.
no more questions.
Okay, so we'll move on to the end for the vote of the thanks. The vote of the thanks will be delivered by Dr. Dilip Vasnik, sir, Honorable Secretary, ISA-NCB. Over to you, sir.
Good evening, everybody. On behalf of ISA-NCB, I extend my heartfelt gratitude to each one of you for gracing online webinar with your presence today. Special thanks to our esteemed speakers, respected Dr. Pankaj Kundra sir and respected Dr. Deepali Mandlik madam, who shared their invaluable insights and knowledge, enriching our understanding on these topics. We express our deepest appreciation for their time, expertise, and dedication. We are very thankful to our today's chairperson, respected Dr. Bhau Rajurkar sir, for his valuable inputs and precious time. A special thanks to SAMS for providing us this Zoom platform. Special thanks to respected President SAMS, Dr. Balaji Asegaonkar sir, and Honorable Secretary, Dr. Tagarpalli sir. And special thanks to Ganesh for the technical support from the Genka Solutions. I am thankful to today's MOC, Dr. Om Shubham Asai, for his flawless conduct of the program. Thank you so much. I am very thankful to the SAMS GC, Dr. Sheetal Madam, for her presence, Dr. Palivar sir, and also respected Megha Tajni Madam for her presence in our today's webinar. Thank you so much.
Thank you, everyone.
Thank you, sir. So we will end our webinar today, episode 3. Thank you. Thank you, everyone.
Thank you.
Hello, sir. Can I end the meeting?